Hello, I am Dr. Kamran Hussain and today we discuss heart blocks and its types. Then we detail discuss first degree AV block, and in AV block we discuss its pathophysiology, the etiology, prognosis, its clinical presentation, its differential diagnosis, investigation, management and clinical cases about the uh, first first degree heart block. Now, heart blocks are also called atrioventricular blocks are further divided into three main categories: first degree AV block, second degree AV block, and third degree AV block. Second degree AV block also divided into two types: Mobitz type 1 and Mobitz type 2. Mobitz type 1 also called sometimes Wikiback, and third degree heart block are also called sometimes the complete AV block. Now, first degree AV block. What happened in first degree AV block? The prolongation of PR interval on ECG more than 200 milliseconds. Its mean more than 200 milliseconds mean greater than 5 small boxes on ECG. Now, normal PR interval is 120 to 200 milliseconds. Its mean 3 to 5 small boxes on ECG. Now we consider marked first degree AV block if it exceeds greater than 300 milliseconds. And in AV node conduction is in first degree AV block conduction is slowed. There is no misbeats. It means every atrial depolarization or SA node depolarization transmitted to the ventricles without any missing beat, and therefore the ventricular rate is regular. And now we will discuss pathophysiology. Before we discuss the pathophysiology, I would like to discuss conduction system of the heart. Now we will discuss the normal electrical activity of the heart. So first of all, electrical activity or heart atomicity generate in the SA node. Now there is a question about on USMLE steps where about the location of SA node. SA node is located near the junction of superior vena cava. This is the superior vena cava and this is the right atrium. So the SA node is present at the junction of the superior vena cava and at right atrium. So action potential generated in right SA node, then it is transmitted to the AV node through the different internodal tracks. There is the anterior internodal tracks, middle and posterior internodal tracks. So the excitation or current is passed from the SA node to the left atrium as well through the Beckmann's bundle. Now, after atrial depolarization, current reaches to the AV node. Here is the tricuspid annulus, and it is present dorsal to the tricuspid, and here is present in the coronary sinus. So the AV nodal gross anatomy location is dorsal to the annulus of the tricuspid valve and superior to the opening of the coronary sinus. And from here there is the certain milliseconds of delay in the AV node. From AV node the current is passed to the His bundle. This is the His bundle. His bundle is then divided into the left bundle branch and the right bundle branch. Then the left bundle branch is further divided into the anterior fascicle and the posterior fascicle, and then these bundle branches further divided into the small branches which are called Purkinje fibers. Now the questions on the USMLE or other steps can be about the location of the these SA node or AV node or bundle, and about the arterial supply. The SA node is supplied by the right coronary artery. So the infarct of the right coronary artery can lead to the dysfunction of the SA node, and the AV node is also supplied by the right coronary artery in most of the people. by the posterior interventricular branch. So mostly in there will be the question about the dysfunction of the AV node, and dysfunction of the AV node mostly occur in the inferior wall MI. Inferior wall MI, there will be the bradycardia and AV nodal dysfunction we discuss in detail later on. Then we will also see that there is no conduction pathway between the atria and ventricle except the pathway of the AV node. So current cannot pass through the atria to the ventricle except through the AV node. If there is any other accessory pathway, there will be the other arrhythmias like Wolff-Parkinson-White syndrome. And it is very important about delay in the AV node, as if the current pass without a delay, then atria and ventricle contract at the same time and there will be no proper cardiac output. Now about the pathophysiology of the first degree heart block. In first degree heart block, the delay can be in the AV node, and there are most likely chances there will be the delay in the AV node in most of the cases. Delay can also be in His bundle, in left bundle branches block, but most common site of the in the first degree heart block, the location of delay is the AV node. Then there also be the delay in these intranodal tracks. And how we will differentiate that the delay is in the AV node or in the bundle branches or His bundle. If there is a normal QRS complexes, then the most probably cause of the first degree heart block present in the AV node. But if there is the narrow QRS complexes or wide QRS complexes, and there is the morphological changes in the QRS complexes, then there will be the chances that it's infranodal, it's inferior, the cause lies inferior to the atrioventricular node. So here dysfunction of the AV node is much more common than the dysfunction of the His Purkinje system. Then if the QRS complex normal with normal weight and morphology, then conduction delay mostly always in the AV node level. And if there is the bundle branch morphology or different morphology of the QRS complex, then the conduction delay is most likely in the His Purkinje system, as we discussed in the diagram. Now we will discuss the etiologies or risk factors of the first degree heart block, and many of these are also present in the risk factors and etiology of the second degree and the third degree heart blocks. And we will discuss one by one. There will be the intrinsic AV nodal diseases. There will be enhanced vagal tone, as vagal stimulation cause more refractory time of the AV node and delay in the AV node. Will be the prolonged PR interval. Mostly it happened in the athletic training persons, those who are athletics, their vagal tone increase and there will be the bradycardia, or there will be the chances of first degree AV block. Then there is the chances of the that acute MI, especially the inferior wall MI, as I earlier discussed that in inferior wall MI, the posterior interventricular branch is blocked or the occluded, and that will also supply to the AV node. That's why there will be the chances in inferior wall MI, there will be the first degree AV block. Then there is the myocarditis, the inflammation of the myocardium can also cause the inflammation of the conduction system and can cause first degree AV block. Then there is the electrolyte disturbances, hypokalemia and hypomagnesemia disturb the action potential of the AV node, and there will be the increased refractory period of AV node, and there will be the conduction delay and can lead to first degree AV block. Then there are some drugs which can increase the refractory time of the AV node. resulting in the slow conduction. The drugs are class 1 antiarrhythmics, and class 1 antiarrhythmics includes quinidine, procainamide, and disopyramide. Then there is the class 1C. Class 1C antiarrhythmics include flecainide, aconide, and propafenone. Then is the class 2 antiarrhythmics, which are the beta blockers. And there is the class 3 antiarrhythmics, which are the calcium channel blockers, verapamil and diltiazem. Then there is the class 4 antiarrhythmics. Class 3 antiarrhythmics include amiodarone, sotalol, diphethylide, and ibutilide. And class 4 are include calcium channel blockers. Then and these calcium channel blockers, on the other hand, we cannot the patient with first degree AV block, we cannot prescribe them these drugs because they can increase the PR interval. And then there is digoxin, and one of the mechanism of digoxin is increase vagal tone. As there will be the increase vagal stimulation, there will be the increase PR interval. And the other glycosides and magnesium. Then there is the idiopathic degenerative diseases of the conduction system, that is Liv disease and the Leningri disease. In both of disease, there are the calcification and fibrosis of the heart muscles and the conduction system. The fibrosis and the calcification can lead to the conduction delay in the AV node and infranodal, and that can lead to first degree AV block. Then is the mitral and aortic valve annulus calcification. I will show again you diagram. So here we discuss as this is the aortic valve, and this is the his bundle. If there is the calcification of the aortic valve as in the aortic stenosis, and if there is the in the rheumatic heart disease, if there is are infective endocarditis, is the annulus abscess. In some patient there will be the annular abscess of the aortic valve, and this will can cause the conduction delay in the his bundle or infranodal pathway. So the next etiologies are infectious diseases, which can cause the first degree heart block. At the infective endocarditis can involve the heart and endocardium and conduction blocks. The diphtheria in the late stages are complicated diphtheria, rheumatic fever, Chagas disease, and we know Chagas disease can cause heart blocks first degree, second degree, and can also be third degree in some cases. But this block can be reversible. If we treat the disease, then there will be the return of the normal ECG. And there is the Lyme disease, can cause the AV blocks, and the tuberculosis, vulvar ring abscess, as I earlier discussed this. Then there are the collagen vascular diseases, the rheumatoid arthritis and SLE and scleroderma. All the diseases can cause fibrosis, calcification of the heart and the conduction system, which can lead to the first degree AV block or other blocks. Then there are the iatrogenic cases, which can cause the first degree AV block or higher degree AV blocks. For adenosine stress testing, this can be the transient, and it can will be later on normal. After catheter ablation of the fast AV nodal pathway, for example in Wolff Parkinson White syndrome, or in those patients which has AV node with fast conducting pathway and the slow conducting pathway. If we ablate the fast conducting pathway, then there will be then current has to pass through the slow conducting pathway, which can be lead to first degree AV block. Then there is the method for closure of ASD using the Appletzer septal occlude. This can cause the first degree AV block. Then the other causes are the following: cardiac surgery, right when heart catheterization, and there are the inflammatory diseases, for example cardiac sarcoidosis. In this, the collagen and the calcification and the fibrosis of the tissues and conduction system can cause the first degree AV block or higher degree AV blocks. Now we will discuss the prognosis of the first degree AV block. In isolated first degree AV block has very good prognosis, and there is no complication in isolated first degree AV block, but in other conditions or with other diseases, for example, first degree AV block with MI or first degree AV block with other diseases as we discussed earlier, SLE or scleroderma, sarcoidosis, there will be the variation or varying of the prognosis will be vary according to the other disease. There is a very uncommon progression of higher blocks unless the infranodal block. It's mean the infranodal block has has more chances to convert into higher block as compared to the third isolated or AV nodal conduction block. Then there are more chances of higher degree AV blocks in patients with other diseases. Now in clinical presentation we will ask about the history, and in history we ask about all the risk factors and etiologies we already discussed, and we rule out the different conditions as we discussed in the etiology, and there will be the no findings on physical examination if there is the isolated first degree AV block, because it's generally an incidental finding noted on ECG, and there may be in some patient the intensity of the first heart sound is decreased in patients with first degree AV block in some of the cases. Then there is the differential diagnosis of the first degree AV block. There is the atrioventricular block, atrioventricular dissociation, the second degree AV block or third or complete degree AV block been included in differential diagnosis. Now we will move to the investigation and especially ECG. Uh, the first degree AV block is actually the incidental finding on ECG. There is no need of other laboratory studies in first degree AV block. We can do the electrolytes and drug screening if we suspect the metabolic disturbances are present. So first of all, in the ECG, we will see as we see in the before we read the ECG, we see the rhythm. What is the rhythm? In this case, as there is the RR interval R on equal duration, so the rhythm is regular. Then we will calculate the heart rate of the patient, and as we earlier discussed that heart rate can be calculated in regular rhythm 300 divided by number of big boxes between the R and interval, and they are approximately 4. So in this heart rate is 75 per minute. Now we will see the PR interval, and PR interval in the first degree block there will be the equal PR interval, and here is the PR interval is of 9 small boxes, which is greater than 5 small boxes and greater than 200 milliseconds. And now we will discuss the other ECGs which are the 12 lead ECGs. In this ECG there is the regular rhythm, as there is the equal distances are the RR intervals, and also the rate of this is this approximately 75. Now we will see the PR interval. In lead 2 PR interval is from this to from this here, and if we will see the here the PR interval almost 6 small boxes, and these are equal to 240 milliseconds, and this is greater than 240 milliseconds. That's why this ECG show the first degree heart block, and we will see there is no other findings like uh, mm, bundle branch block or MI findings. So this is the this is the ECG of an isolated case of the first degree AV block. Then we have an other ECG of the patient. In this case, the RR interval are equal and the rhythm is regular, and the heart rate of this patient is approximately 60 beats per minute. And now we will see the PR interval. From here you will see that PR interval is prolonged, and it is consists of almost 8 small boxes. So the PR interval is approximately 320 millisecond, which is the greater than 200 millisecond, and this show the case of isolated first degree AV block, as there is no other abnormal findings in the ECG. So now we will discuss about the management of the first degree heart block. In asymptomatic patient, there is no treatment is indicated, and those patients with the marked first degree AV block, that is as we already discussed, if it is greater than 300 milliseconds, then what we can do the placement of dual chamber pacemaker. American Heart Association and American College of Cardiology and Rhythm Society, American Society give the criteria for the placement of dual chamber pacemaker placement in patient with a first degree AV block, if it is marked, or if it has the symptoms like syncope and palpitations and other symptoms, as if the PR interval markedly increase, then there will be the loss of atrioventricular synchronization, and there will be the poor cardiac output. So the in those patients we will do the placement of the dual chamber pacemaker. Then before we do the placement implantation, with patients with severe bradycardia and possibility progression to higher degree AV block, we prescribe medications temporarily, and that will be the atropine, which increase the heart rate and decrease the AV node refractory period. Then there is the isoprostanoid, which can also decrease the refractory period of AV node and increase the chronotropic and inotropic effects. Can be given and in anticipation before the insertion of cardiac pacemaker. Then if there is other conditions like MI, we will treat that condition, or other conditions as we discussed in etiology, we also treat them. Then if we suspecting there is the electrolyte disturbances, or if there is the drug toxicity, we do the test and try to correct them. In long term monitoring of first degree heart block, there is the no if there is no presence of any other disease or requirement of hospital admission, we can discharge the patient and follow up in OPD with serial of ECGs, so that we can evaluate the progression into the heart blocks. Now we will discuss the clinical case related to the first degree AV block. A 60-year-old man comes to the clinic for the follow-up of hypertension. He was diagnosed with hypertension 10 years ago. He has treated with the number of different medications, and however the patient had to discontinue the medications due to the side effect like dizziness, palpitations and headache. Now he is taking enalapril, which is the ACE inhibitor, and chlorthalidone, which is the thiazide diuretic, and tolerating them well. BP is blood pressure is 160 by 92, and was 158 by 88 at the last recent prior visit. ECG is shown here. Is the ECG is present, and which of the following medication should be the most effective for lowering this patient? Now the patient is of old age and hypertensive, and patient having taking different medication to control the blood pressure and having the side effects, so they prescribe the enalapril and chlorthalidone, but blood pressure is still high and they want us to prescribe the medication which do not affect its ECG. Now we will discuss about the ECG here. The RR interval are of equal duration. So in this patient there will be the regular rhythm, and as we say, this patient has bradycardia and prolonged PR interval, which is approximately nine boxes, and there will be the approximately 360 millisecond, which is markedly increase, and he wants us to prescribe the medication which do not affect the ECG findings or worsen the ECG abnormalities. So what we will prescribe, either we will prescribe the diltiazem, metoprolol, fedipine, sotalol or verapamil. So we cannot prescribe diltiazem or verapamil as there are the calcium channel blockers and they further increase the PR interval, and we cannot prescribe metoprolol as it is beta blocker and can increase the PR interval, and we can also cannot prescribe sotalol which is the class 3 antiarrhythmics, and it can also prolong the PR interval. So we will prescribe the nifedipine, which is the dihydropyridine calcium channel blockers which do not affect the PR interval. From this our topics end. Good.